Welcome, everybody. My name is Sean Lisha. I'm with Wison Sonsini. Today, we're going to do our digital health webinar series, session 3 on value-based care, the building blocks of success. Joining me today is Gail Zahtz from Zahtz Partners, the managing director there. When we launched this digital health webinar series, one of the goals we had in mind was not just to have a whole bunch of lawyers talking to you from Wison Sonsini, but to really partner with experts from the industry so you could hear directly from them. Today is our first one of those sessions, and we're going to be talking about value-based care, as I mentioned. First, some legal jargon. This presentation does not constitute legal advice and was created for informational and educational purposes only. That's the lawyer in me coming through. Those of you who joined our seminars before or know about Wison Sonsini in general, one of the things that we focus on is technology-enabled companies. And in this case, we're doing that in the healthcare space, so digital health. And today we'll focus on value-based care. We pride ourselves on the right advice at the right time at the right cost. We have over 400 digital health clients, including those in the value-based care space. We have a highly experienced cross-disciplinary team. Keep a lookout for future webinars. And here's just a sample of the team that we have. This is just a representative sample of the people who are working on our digital health initiative here. Oops. And we'll send around these slides in advance at the end about how Wison Sonsini really prides herself at understanding the digital health clients' needs. I myself spent 9 years in-house, and we have people on our team who have spent their entire careers at the law firm, and together we bring an in-house perspective and an external counsel perspective together to give you the best advice possible. For those of you who need CLE for today, the CLE code is 432FWN, 432FWN. And without further ado, I'm going to turn it over to Gail Zahtz. She will lead us through our presentation on the building blocks of success. Take it away, Gail.
Thank you so much for having me. I'm so excited. In discussing setting this up, there's kind of two ways you can approach this kind of information, right? Deep or wide. And we decided to go wide so that you could hit on a bunch of different areas that you need, and then decide where you want to go deep on yourself or members of your team. Just so happens that HealthBZ.Academy is opening next week. It's first cohort that's public ever. So anything that you want to go deep on, you'll be getting. There's a 10-week course, plus it's unlimited for the year. So let's go wide. So where we're going to start is these are building blocks for success, right? So we're going to be going through a few minutes of each of these, sort of what do you need to set up in your organization? What do you need in order to be successful if you're selling into a value-based organization, if you have solutions, if you need to set it up for yourself, if you're contracting? My hope is that you'll look at this depending on what hat you wear and start to see what are the areas that we really need to dig into. And I know a lot of you are really already experts in this space, but I like to kind of step back and give my view of sort of the difference when we're talking about fee for service versus what is value-based care, right? Specifically, what is value-based contracting, right? Because what we are talking about today is really the nuts and bolts of the business. We're not talking so much about how do you do more clinical value. And within the business gives the opportunity for profit and also for doing well by a lot of people. So this is kind of like a Gail Zahtzism analogy. When I talk about fee for service versus value-based care, I talk about the sidewalks. So imagine this, you're walking on the sidewalk, it's broken, right? You trip and you fall. You bust up your arm, and then you need to go into the emergency room, right? The emergency room checks you. They put down for a fee that they're going to charge for getting you in. You get another fee for the scanning. You get a different fee for the doctor to read it. And you get a totally separate bill for a fee for physical therapy that you need after the fact. This is a fee for really sickness, right? The only time that the doctors or healthcare providers or even the hospital facility is getting paid is when you come in because you fell, because you're sick. And so what you're doing is you're financially incentivizing volume, right? The only time I'm going to get paid is if you fall on that sidewalk, hurt yourself, and need to come in. When we talk about the switch to value-based care, instead of paying the doctor, the hospital, the pharmacy, each separate for this service of sickness, you're getting paid for taking care of a population, and you're going to get paid basically the same, particularly in your profit, if the people don't come in. So suddenly what you're doing is you're financially incentivizing people to not fall on the sidewalk. And now there is a strong financial incentive for you to fix that sidewalk and keep it fixed everywhere, because you'll keep getting paid even if I don't come in. And when we talk about health equity, we say there needs to be one of these safe sidewalks in every neighborhood, right? It doesn't matter the socioeconomic. And that's really what health equity is. Now, why are we doing this, right? And you've probably all heard about the triple aim. And maybe you're going to tell me, but there's the quadruple aim. I will tell you the quadruple aim has not been officially recognized, so we're going to stick with the triple aim. So what happened when the, what you may know as Obamacare passed, they were saying, like, we need to lower the cost, right? The health systems are going bankrupt. The biggest purchaser of healthcare in the United States is the federal government, through CMS, the Centers for Medicare and Medicaid Services, and then also through Medicaid at the state level and the veterans and many other ways. They're the biggest purchaser. They purchase most of it from the Social Security Fund, and that fund is going bankrupt. So they're like, we have to lower the total cost of care, but we need to do it while people are still having good health outcomes for an entire population, not just one-on-one. And we need the patients to feel that it was a good experience. So we lower the total cost of care by comparing it to what we call a benchmark. A benchmark is what we thought it would cost to pay for this particular person, like what we think it'll cost next year, for us to pay for the population of people who live in the area where you are aligning, okay? If you want to lower the total cost of care, you want to improve the outcomes for a population, because now people are responsible for a population, not a one-on-one visit. And how do we know it was a good patient experience? We have a thing called a CAP survey. So when you're thinking, as we're going through these success milestones and all of that, keep coming back to, is the decisions that we are making as an organization meeting at least one of the AAA? Because all of success in value-based care is going to be determined with whether or not you are meeting at least one of these three goals. How did we get here? Now we're going to go real quick, okay? We could be doing this for like days. Medicare started in 1966. It was an add-on to the Social Security Act, which originally was just for healthcare for 65 plus, for really terrible emergencies. What we would now sort of call Part A of Medicare, which is you go into an acute hospital situation. That is what Medicare started, 65 plus. Later, it became also people who are permanently disabled. And later, it expanded to cover people based on economic necessity that went to the states for Medicaid. And it sort of grew from 1966 until the mid-90s, where lots of legislation adding pieces on. And in the 90s, for those of us like me who are old enough to remember what healthcare was like, you were looking at a lot of attempts at managed care. Like if anybody remembers HMOs, the old HMOs, the idea with managed care was we're going to give you one lump sum. The difference is there was no connection to quality, which you saw later also with Medicare Advantage, and it was a closed network. You could only see our doctors. Coming out of this managed care, Medicare Advantage started. Now there's 4 parts to Medicare. Part A is your hospitalization. Part B is your outpatient. Part D is your drugs, and Part C is what you may now call MA or Medicare Advantage. That started in '99, and that is value payments, meaning you're getting a capitated payment, which is a full payment against the total cost of care, but closed network and no initial connection to quality. Meaning, one of the pushbacks coming out of this kind of managed care era was people can do a terrible job. They're going to get the same amount anyway, right? And that's sort of what you see starting to get fixed later in the 2000s. In 2010, the ACA passed, and you all have heard of the ACA. You know about Obamacare. You know about sort of the expansion of Medicaid. But in that, they said, wait, we need to do alternative payment models to lower the total cost of care and reach the rest of the AAA. But how do we do that? So kind of in like the last inning, Congress passed CMMI, which is the Centers for Medicare and Medicaid Innovation. And what that is like, for all of you who are in the startup space here, that was like an incubator that said, we're going to try models through CMMI, and we're going to learn how to connect payments with financially incentivizing people doing what we want them to do, which is provide better care at a lower cost. And so in the course of this time, over 40 models have been put out. The models were all for the triple aim: lower the cost, improve the outcomes, improve the experience. And guess what? Most of them, almost all of them, have failed. Almost all of them have failed to reach the AAA. But a couple of them have succeeded and therefore become permanent. And others have given us pieces of what works. And sort of if you look from 2010 to today up to 2030, which is when CMS says, that's it, we're done. We want everybody in a relationship, in an accountable relationship by 2030. So we are on that clock, right? And you see pieces of what has worked that goes into what you're going to know as sort of permanent requirements in the next few years. So we get good at those pieces because they tell us how we're going to be successful in the coming years. MACRA, and I'm going to like jump through this really quickly. MACRA was the big decision that people don't talk about, in my opinion, often enough, where we really started adding quality. This is where we started saying, how are we going to connect this care at hopefully a lower cost with good health care, which is what we call outcomes of the populations. And quality also includes the patient experience, what their feedback is. In 2020, we saw the movement towards what's called two-sided risk, which means the idea, and we're not going to be able to talk at length about risk, although it's one of my favorite topics. But with one-sided risk, it says, if I fail to lower the cost and improve the outcomes and experience, then, you know, that's sad, right? But like no skin off my back. But two-sided risk says, if I succeed as an organization, we're going to earn more. But if we fail to lower the cost and improve the experience and the outcomes, then we're going to have to theoretically or for real pay you some money back. So the movement of what you see here, and why I put DCE as like a plant in a major milestone, is that it was the shift to two-sided risk. And what you're going to hear about of capitation, where you started getting a subscription, a monthly PMPM, a per member per month, that you get against the benchmark, typical like MA, but connected to quality. And that all kind of got rebranded. It was called DCE. I was super involved in this. I'd love to tell you guys stories about this period. It was actually super interesting. It got shut down, then it got like changed, and it became GPTC. And then when it all came about, it became what's called ACO REACH. And over 300 organizations applied for ACO REACH. CMS only accepted half of them. But ACO REACH became really, really what we're going to see in the movement towards capitation, two-sided risk, paying for health equity, not paying if you don't have health equity, and sort of a lot of the pieces moving forward. So much so that several models that have launched this year that are going to be actually starting next year have really been based off of ACO REACH. So I feel if you're going to learn one model, ACO REACH gives you a good opportunity to do that. 2030, again, is where we're going to see everybody has to be in. So in order to be successful, right, we are talking about healthcare. The major shift in care is all about primary care. Because what happens is that if I'm paying you for a service, right, for a visit, for a clinic, I need to come see you, right? Either in person or at a much, much lower degree in telehealth. But I need coders who are going to connect what was done at this visit and how to pay for that visit. And from this sort of typical fee for service, you have over 10 different payment models depending on where the person gets care. So if you're receiving your care in a hospital in an acute setting, that hospital is paid on a prospective inpatient payment system, which has pieces in it that you may be familiar with, like DRGs, diagnostic groupings to pay for, CPTs, which are the payment mechanisms for every possible piece of the procedure, okay? But when you move to value-based care, that goes away. You're no longer getting paid for the visit. So now what you want to think about, whether or not you are a provider group or a technology solving to it, is how do you solve to a health system without walls? Because suddenly now I can give you advice at Starbucks. I can talk to your caregiver. Like, I can meet you at the community center. Like, there's no longer a need because I don't have to bill for an episode of service. I'm getting paid just to keep you well. So this is where the pieces come in: chronic care management, free transportation, care coaches, home visits, call centers, telemedicine, right? These are all these solutions that many of you are working on providing that solve to how do you provide high touch, early intervention, very involved primary care, particularly the 90% of primary care that does not happen in clinic, right? How do you support that? And supporting that is, again, remember though, lower the cost, improve the outcomes, and improve the set and improve the experience. Now, how do we say it's been a better patient experience? They do what's called a CAP survey. What the CAP survey is, it's a very long, arduous phone survey that third parties are contracted to be able to do, that calls a randomized group of patients who are attributed to a healthcare provider and asks them lots and lots of questions. Now, here's the thing. What has absolutely been shown is that because you're getting that patient at a moment in time, you're saying, oh, okay, Sean, how was your experience? Now let's dive into what it was like when you saw Dr. Gail 10 months ago. What did you think? And we absolutely know that you're going to answer based on your last experience with me, right? So we could have had 9 months of great visits, but if I call on that day when you're mad at me or my nurse didn't do something, then suddenly, right, the CAP survey tanks. And so what often happens is that you see on the CAP survey the best and the worst input. So, but what you should be and need to be doing is preparing your patient the entire time and creating ways of engagement and input. And there are apps, or your apps or whatever that you're creating can connect to this, right? How do we keep the patient experience going, and how do we know how do they feel? These are all of the different segments that go into the CAP survey. In addition, for success in value-based care, you need, for the first time ever, particularly with ACO REACH was the first time it was required, to have a beneficiary or more, depending on the model, as part of your governing body. And this is where the legal team here will be able to help you, because it really actually matters how you set this up. And it matters when you set it up. And it matters to whom they talk. But also, how do you find a good patient, right? You have to suddenly start having a patient voice at the table. And the other is, how do you start making them partners in care enough that they get involved in all of the extra goodies that you're giving them to keep that high touch early intervention? So for example, do you have an app? And if you do have an app, how are you engaging the patient so they're using the app, right? How are you like connecting the dots and frankly, continuing to make sure that that connects to how they're going to respond to how they feel their experiences? And I give you this as, again, we can't go into all the details. This is years that my team has worked on creating this kind of care journey. But I wanted to share it with you so that you could see, particularly for this audience. I know a lot of you are like starting some incredible new things in the startup world. You'll see, if you kind of follow the patient journey, where we can make a huge difference. So the concept with this is that we need to be talking to people. The biggest cost of care is in transitions of care. That is where the vast majority of money is lost, not in referrals, but really it's not. It's really in transitions. When somebody comes from acute to post-acute, from post-acute to home, from home to, right. And how do you, and I'm sure you all have heard this, avoid preventable readmissions? Right? Because no matter what the model is, your payment or your client's payment is going to be directly linked to whether or not people came back into an acute setting, particularly in less than 30 days or 60 or 90 from when they left. And the way you do that is by being super involved with them. And so what I wanted to show you just was this encounter resolution here, which is, let's say somebody from our call center calls patient Sean and says, how are you doing? How was it? And Sean says, I don't speak English. and you say, okay, no problem. We're going to connect you to a translator on this call. Or Sean says, man, I'm not feeling good at all. Okay, why not? Well, I'm really hungry. Well, like we went over your diet based on the fact that you're a diabetic. So why don't you like go take one of the oranges we recommended? Well, my fridge isn't working because I don't have electricity. Well, guess what? Maybe connecting the electricity is far cheaper for the pay provider than bringing you back to the hospital. So let's get, if we're a health insurance organization that'll pay for a handyman, let's send a handyman. Let's get you with the doctor. Let's connect you right now to a telehealth visit. Let's send somebody to your house. Oh, you need your medication? You don't need to talk to a doctor for that. You already have a script. Let's connect you right now to a pharmacist and a delivery, right? So I just wanted to show you this for a second for you to start thinking about your solutions and what you're working on and how that can fit in to the triple aim, lower the cost, improve the outcomes, improve the experience, in the 90% of what happens outside of healthcare, outside the clinic. I want to show you this. I'm going to skip over this for a second and show you what I'm talking about. So this is all evidence-based. You say, okay, it's costing the average benchmark, which means the average cost of care is around $12,000 per person. It runs 12 to 14, depending on the risk. We don't have time today to talk all about risk adjustment, though. It's another one of my favorite topics. But when you talk about, okay, we're spending, let's say $1,000 a month, right, to treat Sean. And how much of that $1,000 actually is impacted by what happens in the clinic? 10 to 20%. That's it. Right? So if everybody, and I hear this all the time, particularly from startups, I've got this amazing heart monitor that prevents people from coming into the hospital in 5 years. It lengthens the life. It reduces ulcers of the leg that are super expensive 5 years from today. But here's the thing. Almost no one who is paying for the health care cares about what happens to that patient in 5 years. Because I have no idea, if I'm an insurance company and Sean is one of my members, I have no idea if he's going to be my member in 5 years. Maybe he's my member because he came in through an employer self-pay plan and I'm actually not the insurance company, but I'm actually a benefit administrator, but Sean doesn't know it because it's an employer self-pay plan. Or pick 20 million other reasons. Most executives, and therefore the people that work for them, know that it's very unlikely that I care financially what happens to my patient in 5 years. What I care about is this year's bill. And the well-being, and therefore the cost and experience and outcomes, you see has impact from many other things. And this is kind of where you start getting into social determinant solutions and why you get into, oh, maybe it makes sense for us to pay for transportation. Why? 10% of whether or not this patient is going to be well is based on the physical environment, and they're never getting to their appointments. So I know health systems who spend over $1 million a month, health systems, not payers, health systems, over $1 million a month, just providing free Ubers or Lyfts, right? Because I can do the math with my actuary team and figure out that actually the cost of the Uber is going to be cheaper than the loss if I didn't offer this to my patients. And so if you look at this chart, I really like this. It gives you insight into the other areas that impact the well-being and therefore impact the cost. Where I tied this into was the notion of health equity. Remember, health equity is sidewalk, safe, every neighborhood. You've heard it talked about ton and ton and ton. The real issue is that what they have found since, particularly the ACA and all of the data that's been collected, the failed models and all of that, is that most of this care has been given to, people who are white, middle class, like in a particular demographic. And so what happened, though, is that I want you to look at dual eligibles for a second. So what's a dual eligible? A dual eligible is somebody who receives Medicare and Medicaid or is eligible to receive Medicare and Medicaid. So what do we know about a dual eligible? We know that they're over 65 or permanently disabled. We know that they are financially in need because they're below some financial marker, okay? And less than of all of the Medicare beneficiaries, I'm just going to use Medicare because the numbers make sense. About half of your Medicare beneficiaries are on Medicare Advantage. And then about half are on what's called traditional Medicare. Of those, less than 20% are dual eligible. So this they're poor and they're older, or they're poor and they're disabled. And yet, almost 40% of the total cost of care in traditional Medicare is from dual eligibles. So why does CMS cares about health equity? Because they're good guys and they want the world to be a better place and everybody should have health care. That said, it's double the cost, right? So they're saying we have to actually really look at people who are costing more because they need more. The area deprivation index is the most widely used way of using it. I will tell you it's going to change because people have issue with how accurate the ADI is, particularly in cities like New York City. But that said, it's a free resource. It is connected directly to health equity bonuses. And so I'm not going to get into all of the minutia of how the bonus works or where the money comes from or based on which model, but I'm going to tell you that financially paying attention to health equity in the area deprivation index, particularly as we move forward, is really, really super important and could change the entire bottom line of a healthcare organization from hinging on bankruptcy to profitability. Now, it is not mandated yet. What is mandated right now is this growth towards data collection. So if you're in the data space, you're going to want to be looking at how can we help providers collect information about what social determinants patients need. A social determinant is something that happens outside of clinic, right? If you remember here, outside of clinic that impacts whether or not I'm healthy. And so it could be like just some basics. Like, let's look at some of the kinds of questions and the kinds of answers that can impact. Are you safe? Well, no, actually, there's like bombs coming down and I'm not safe and therefore I can't get good health care. Or I'm in a domestic violence relationship. 1 out of 5 women have been in a domestic violence relationship in America, right? And so you say you're being like safe and taken care of, but if you're not safe at home, then how likely is it that you're going to get the health care that you need? Do you have food? Do you have access to food? We hear things about like food deserts and that sort of thing. And do you have, transportation, just kind of like all of those basics? And what we're going to see is a move towards then doing something about it. We're not there yet. But for those of you who are kind of newer coming into the SDOH space, you're going to start seeing it's absolutely the right thing and the nice thing to do right now. And I would say within 24 months, it's going to be mandated. So you can help your clients get good at this. You will also need on the new models a health equity plan. And that actually has requirements on what the plan has to be. Again, your attorneys here can help you with that. And also sort of like how you involve them in governance and how you account for the health equity so that you can have more payments in order to provide more care. Now, this piece is often missed, the provider contracting. Let me tell you like kind of the way people often think about it and how I think about it. So remember your benchmark is your total cost of care. So we'll call that 100. All right. And we're just going to call it 100 right now for an even number. All right. Of the 100, every $100 spent, primary care is 4 to 6% of the total cost of care. Primary care is only 4 to 6%. Now, so you're paying a primary care doctor off of this 4 to 6%, and you still have all of the rest of the cost of care to deal with. So oftentimes the thinking is we're going to go contract with doctors and we're going to tell them they have to take a haircut, right? You have to take a discount because that's how we're going to like make money because we're doing value, but we're going to share in it. We're going to share in the risk. We're going to like split up the shared savings and we're going to like, and the reality is that most of that shared risk are things that your average doctor can't even control. Like you're paying them on whether or not you provided enough services against the area deprivation index. And that doctor is in a red zone, but 95% of your patients are not. They could be providing health equity services and not get paid any of it because you still won't hit your quality line. I know that some of that must have just sounded like, blah, 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 blah. We didn't understand a word you just said. And part of that is because I can't really get into all of that minutia. So you just trust me. It's a bad plan, not legal advice. But like, why focus on paying your individual doc like $10 less that is like legit going to make or break whether he likes working with you, rather than saying, let's work together. I'll pay you more. Now let's figure out what we do about the 96% of the cost together. And as we're doing that, I'll give you another %, right? So because the entire success is based on what your network looks like, even though we don't call it a network anymore, but we have no good word for it. So we'll call it a network. Who are the people providing care? To whom are they referring? Are you getting the best quality at the lowest cost for the total cost of care? Hang on with me on this. That means who cares if I pay my doctor double what anybody else is paying him? If I keep the rest of my costs down, because that doctor makes sure that every person gets seen rather than having to go to the ER. Like, there's so many solutions to this. So, but the typical way that most people are doing this is really, really sowing a lot of bad blood between doctors and payers, right? And you guys have seen that. And the other is that a lot of the providers, there's some really awful stuff going on, do not know when they're being completely lied to, and they are, right? So I have received, I'm not part of your legal team, but people will send me, that I'm under an NDA with copies of contracts that they've gotten and ask me to take a look at it as a friends and family bonus. And I will tell you, I've seen contracts where they say CMS told us we're required to, you must take this discount. And so what happens with the doctors? Let's look through the lens of the doctors. Prior to COVID, we had 30% less doctors than we needed. Okay, so that means in a hospital serving 100 beds, if we needed 10 doctors, we only had 7. After COVID, as a result of COVID, we lost another 30%. That means that every hospital is only staffed at 30% of what it needs to be. So these doctors and nurses are completely overworked and frazzled. They are unable to provide the kind of care that they wanted to. They are being given all of this extra bureaucratic work. 20%, 1 day out of every 5 for your average primary care doctor is now spent on bureaucracy and paperwork. Imagine what you can do if you solve that for your doctors, if you let them be able to practice medicine again, right? So if we look at primary care and non-primary care contracting as an absolute piece to success, you will have these relationships that are so good for the patient, and they're not going to leave. Because if you pay your doctors more and you treat them better, they have nowhere else to go these days. Next thing, and I bet a lot of you are super interested in this technology piece, all right? The reason it's later in these slides is I wanted you to start thinking about the pieces that need to be solved. And every one of those pieces along the patient journey, you can solve to in some piece of technology. Now, let's start at a ground zero on technology, which is you have the EHR. Now, fortunately, the situation is that because of how much healthcare has spent on their current EHRs, that even though when you change the payment from fee for sickness to a capitation on a value-based, and none of your EHR actually is set up to make those payments, most doctors and health systems will put a layer on top. So they're taking the regular EHR and they're looking to layer it on with solutions that solve to everything we've been talking about. Contracting, SDOH screening, quality reporting, bonus payments. So one, please try to have your solutions that you're a part of do a good job at connecting to the EHRs. If you're a healthcare provider system, look at how you can build this first on paper before you add on a bunch of vendors that maybe doesn't work together. Because you're going to need a total system to do this, or healthcare providers, healthcare payers need a total system. And the best way to kind of think about the technology solution is to map it through the patient journey and the physician provider journey. So if you've done journey mapping, you can see each point that comes in, where you really need to solve to and how to make it work together. Now, people do not get paid value-based payments the full amount if they do not meet interoperability requirements. And it sounds like really like, oh, man, we solved to this 10 years ago. Of course, we all know we didn't solve to it. So it's really important, whether you are a solution provider or a provider of healthcare services, that you work with your legal team to make sure that you can check off those interoperability boxes. Like, seriously, it's no joke. I'll give you an example of this. You think, well, like, well, whatever, we'll take care of it. I had a client, they had over 50 locations in New York State, large health system. One of their locations was post-acute, so smaller numbers, less than 500 patients on a census. I pulled up their paperwork just from Optum, right? Meaning just the people who were being paid, their patients who were paid by an Optum contract in that one facility, a very small number. And in one quarter, that health system failed to get paid $1.4 million from Optum because they hadn't given flu shots. Now, stop for a second. Any post-acute, that's your skilled nursing facility that has any post-acute gives flu shots. Here's how they do it. They walk around one day and everybody gets a shot and it gets checked off. Of course, everybody gets flu shots. It's like standard operating procedure. So I go and I say, you didn't get paid $1.4 million from Optum because you didn't give flu shots. So like, of course we gave flu shots. Like, of course we gave flu shots. I'm like, yeah, but funny thing, you didn't report it. So it must be your technology. Oh, no way was it our technology. Our tech system absolutely meets the interoperability requirements and absolutely reported it to Optum. I bring the technology team in. I say, yeah, so funny thing, we didn't get paid $1.4 million because we didn't do flu shots. They said, of course we did flu shots. I said, well, then they weren't reported. They're like, of course they were reported. You know where the story's going, right? They weren't. They got lost in some like tech system, right? Because the health system had pieced together 20 different systems and nobody had been paying attention to the value payments as part of the technology system. And they lost $1.4 million in one quarter. And this is not the only client I've had this happen to, right? So really engage with your legal team and you will see that a little bit of focus on making the technology systems actually be interoperable could make you or save you or make or save your clients a lot of money, right? You're solving to something and you sell it for $1 million a year. If you could solve this for the client and you just save them $1.4 million for the quarter and they just keep making more money because of your solution, now you've got them interested. Way more interesting than whether or not Sean has a heart attack in 5 years, because we all know we don't care. But we do care that I didn't get paid for that flu shot I gave him, right? All right. Next is community and faith-based organizations. So you may hear CBOs. CBO is a community-based organization. It really, you actually need to pay attention to this because depending on the model, depending on the state, depending on the year, depending on the position of the moon, up to 30% of the care of aligned beneficiaries may need to go through a community or faith-based organization. The other is that all of these social determinants we're talking about, let's be honest, hospitals are not in general going to start setting up food banks, although maybe it wouldn't be a bad idea, but they'll typically work with a food bank right from the county. Though the churches often have way more interaction with patients than a doctor ever does, right? So the community and faith-based organizations do several things. They enable you to do better referrals. They enable you to get your patients taken better care of at a lower cost. They enable you to provide care at a lower cost. This sort of like of everything that 90% that happens outside of clinic. And with a lot of these models, you're required to. So really it gets lost time and time again with my clients. I see this. They just do not know the importance of success in community and faith-based organization relations. Now, quality, obviously, we could talk about quality till, right? We could talk about quality for months. And it is tough and it's a mess. And it is something that is required if you're going to get paid. the notion between quality is, right, unlike, remember MA, right? I don't want to just give you services and get paid for giving you services or not giving you services and then find out that, Sean had that heart attack in 6 months because I didn't take care of him. Again, not caring about the 5-year heart attack. It has become a pretty bureaucratic, really, really, really big lift. And I know a lot of you are aware of that. And so when you're thinking about quality, I want you to really think about how can you or your organization or a vendor or partner work to make quality something that happens behind the scenes. Remember that 1 in 5 days I told you about the primary care where they're just doing paperwork? Like, they don't want to do it. And they definitely don't want to do it figuring out the coding in order to reach a particular quality measure. And yes, every single model and every single insurance plan has a different list of what the quality metrics are. There is no universally agreed system for quality measures. So what I gave you here is sort of the 4 big categories based on ACO REACH. Because again, the goal is lower number of quality measures. That is the movement. And we see a lot of legislation that's gone towards that the past year. I'm not as optimistic about it being as simple as some other parts of this value-based care are. But if you focus on these 4 things, you're generally okay. So readmissions. It is always going to be about keeping track of readmissions. And so solving to readmissions, but again, not Sean's 5-year heart attack readmission. We're talking, did you know that over 40% of all cardiac procedures end up with a preventable readmission within 30 days? Did you know that over 50% of healthcare costs happen in the last year of life? Right? There are areas where that's what we're talking about preventing, right? We're talking about how if we either keep somebody longer or we keep them safe at home, then we can dramatically reduce that. Remember the triple aim: lower costs, better outcomes, better experience. So number 1, whether you're solving or whether you're partnering to solve, risk standardize, all condition readmission. 1. 2 is readmission unplanned when you have chronic conditions. So this and the timely follow-up with the exacerbation actually can get really detailed based on what the model is. So just to give you like a high level, for example, in ACO REACH, if you have asthma and you come into the hospital and then you come back and I didn't call you and say, Sean, you brought your son in, he had an asthma attack, what can I do to help you? Let's get you back in the visit within whatever the model says, 6 days, 7 days, or 14 days. If I don't do that, if I don't get Sean and his kid back in front of me within the prescribed time, 7 to 14 to 30 days, then I will not get paid on treating Sean's son. So suddenly this minutia of these little examples of quality matter a lot. And so each model and each thing that you solve to will map out. And then again, when you're talking about technology solutions or you're talking about provider solutions or whatever it is, you're going to want to map it to this. And these are the kind of things that we dig way into in HealthBZ.Academy, right, that we can't do right now, but I just wanted to give you a high level. And then, of course, we talked about the CAPS, which is the patient feedback. And that, depending on the model, is going to account for 20 to 50% of whether or not you're going to get paid. And the quality withhold, the money that CMS doesn't pay you or pay the doctor, or pay the pay provider, while we're waiting for true-up, waiting for reconciliation, that money could be all the profit there is. So getting this right and getting it reported accurately and figuring out how to solve to this becomes super important financially, right? And so you really want to spend time sort of setting this up for general quality stuff, not just for each model. And I want to talk about this for 1 second with quality and also with contracting. I have a lot of clients who, you know, it's fine. You're like, okay, we just got an MSSP, like, you know, enhanced track. Let's figure out how we like do our new patient communications or our upgraded reporting, or how do we want to apply for this new model. So let's put everything together just in the application. Point being that it's typical. I would say it's probably mostly happens that people are solving to based on a particular model. And so you say, well, those quality measures are there's 5 measures for that model, so that's what we're going to focus on. But then this other model has 10 different measures. I'm saying that there are really about 20 areas in quality that if you take care of those, you're going to reach your quality metrics across the board. And so I will encourage you, I may be talking into a wind tunnel here, but I will encourage you on all of this to make a plan and have a team. You know, and have that team be continually educated and up to date on everything that's happening in value. You want to invest in the team. And let's talk about that for 1 second, because healthcare is like this big ship, right? It's like this honking big ship that like is really hard to move. And so changing the entire financial model for an entire industry in less than a decade is it's clunky. And even if everybody has to do value-based care by 2030, it doesn't mean everybody's going to be good at it, right? And so you have an opportunity to be an expert in your space to be able to help a lot of people get good at it. And I know people kind of like roll their eyes at compliance and they say, you know, like, and I know that there's like a health system view of like, well, we'll just pay the fine. It's fine if we get caught, like, but guys, seriously, like you should start paying attention, right? Like I know that lots of people like during the No Surprises Act, like it's fine. I'm not going to provide a good faith estimate. It was a ridiculous notion anyway. And so it'll be fine. But you know what? Now they're starting to fine people $10,000 a bill. And suddenly providing that good faith estimate becomes a lot more interesting. You know, I had a client recently who said they had their compliance totally shored up, and their compliance person was reporting to their marketing person who was directly responsible for the marketing messaging. The compliance was the department who had to say, no, you can't send this messaging out, which of course would never happen, which is why the government says your compliance person actually has to report to the board or the CEO. That is just one of many, many examples. It really is not such a big lift to have a compliance manual, to keep it updated, to have reporting. It's a little investment in time to really help you be successful long term. So that's my little plug again for your legal team here. As I said, we are going to dig much deeper into this in our first cohort. I'll tell you, I've been doing this for years now for private clients. And I just said, like, I just know that we need a lot of people to get good at this, not just a few people. And so was able to finally start offering these courses to the general public. For those who missed the CLE code, it is 432FWN. That is 432FWN. And what I also want to do is kind of, you have a Q&A in the chats here. So I want to give you, I really like giving an opportunity if anybody has questions. You came live, and so I want to give you that opportunity to ask live. And also, Sean, on behalf of your firm, if you want to ask anything or bring any input. I don't want to talk to the last second.
No, we'll give people a chance to chime in with questions. You talked on a topic that I think is near and dear to a lot of us, you know, interoperability. Maybe at a high level, just explain what those requirements are and how they're intended to work, what they're intending to accomplish?
Sure. Near and dear to my heart too, right? So the basis is that you have to have all of your basic systems that are reportable into, if we're looking at Medicare and Medicaid, for example, reportable into Medicare's interoperable system. So what they have done is they've set up these like third parties that sort of like create these hubs and checks where you connect your data reporting into the third party that's approved by CMS. The other is that there are system requirements for that. And I will tell you, it's complex. Like it really is. The biggest time I see, and maybe you see this also, Sean, that I see a lot of red flags with this is when a client makes an acquisition, right? And you acquire a new group of doctors and suddenly you have 5 new EHRs that you've never had before. And it happens, and everybody's focused during that acquisition, right? On the payments, on the transfer, on the structure, on the electric bills, on the facilities. And they completely forget to make sure that the quality reporting is connected and interoperable. And by the time somebody notices it, guess what? It's too late. Because if your reporting doesn't happen in real or near real time, depending on the reporting, you don't get paid. So I think that to look at your interoperability, particularly during these moments of transition of an organization, and the other is if you're solving something, right? You're saying, oh, okay, like this widget, if it plugs into the EHR, it will prevent Sean from having those heart attacks nobody cares about. Then you want to make sure that this meets the interoperability guidelines also.
Awesome. All right, I don't see any more questions in the chat. So why don't we say thank you very much, Gail. I really appreciate your coming and being our first outside speaker, guest speaker for these series. Very engaging topic. And if anybody has any follow-up questions, you can reach me or Gail at you can reach out to me, or you can reach out to Gail at she's GailZahtz.com, GailZahtz.com, and I'm at Wison Sonsini.
And you can see here HealthBZ.Academy. The first cohort is starting next week. So that's going to be 10 weeks, and you get not only the 10 weeks live and all of the handouts and all of the recordings, but this first public cohort gets all of the new classes and content for a year. So awesome. I really look at us building this together.
Awesome. All right. Well, thank you, everyone. Thanks for being here.
Thank you for having me.
Have a great day, everyone.